Welcome to this Beyond Zero e-learning module. This module is one of our Wits RHI Advanced HIV and TB catch-up sessions. This particular session will be part 2 of our presentation on failing art in children. So in our part 1, we talked about Thembi, a mom with 3 children. She has a new baby who's PCR negative. And in the previous presentation, we focused on Lerato, who was aged 2 years old, was on abacavir, 3-TC, lopinavir, ritonavir, was also on TB treatment and was virologically failing. In part 2, we're now going to focus on Sipho, which is the older brother of Lerato, and he's 10 years old, he weighs 25 kilograms, and he's treated with efavirenz, 3-TC, and abacavir for the past year. Now, he also was on TB treatment for 6 months before starting ARVs. And his current CD4 is now 400 with a viral load of 23,000. The granny is complaining that he's become very naughty, he's always out playing with friends, he isn't home on time to take his treatment, and their relationship is obviously strained. And you also discover that he doesn't take his art unless it's exactly on time. It's 7 o'clock and 7 o'clock in the mornings and evenings, and the counsellor was very strict on this. So if he's missed his 7 o'clock dose, he doesn't take his ARVs at all. And he keeps on asking why he has to take his ARVs and says it looks similar to the treatment that Queen on Generations has to take. So let's look a little bit at what the issues are here and how they should be addressed and how we're going to manage Sipho. So firstly, importantly, when we are looking at the issues, I'm going to use the same approach that we used with the mom as well as with Lerato, using our ABCD when we're starting to assess and structure our understanding of virological failure. And the first issue we want to look at here is adherence. And obviously, when you have a pre-adolescent 10, 11, 12-year-old who's starting to get grumpy and who is not happy about taking their treatment anymore, it's very important to have a conversation about disclosure. And this has to be an ongoing conversation for children when they put on ARVs, even when they're quite little, to discuss with the family how and when disclosure of the child's status will happen. And we know that by 11, we want all of our children with HIV to already know what illness they have and why they are on treatment. Please see our separate presentations on disclosure. But also, we must make life easier, especially for our older children, giving art times so rigidly twice apart. And do remember that with the abacavir, 3-TC, and efavirenz regimen, you can take it once a day. And we are still seeing many people using the old-fashioned twice-a-day regimen for these children. The new dosing chart has got dosing for once daily dosing. The other issue we need to look at is the opportunistic infections. Has his TB been properly treated? Why is he so underweight? Has he been dewormed? And is there any other infections that might be contributing to the viral load not being suppressed? Under C, we're looking at correct dose and making sure that he's had his weight done recently and that he's on the correct dose for weight. And then D, of course, is drug interactions. He's only 10 years old, but if he was a bit older, you would also, with your teenagers, don't forget about things like alcohol use and marijuana. And hopefully that's not yet an issue with our 10-year-old. So we can use our ABCD to also assess any patient that we see with biological failure. So the next step would be to now figure out whether this viral load is purely because of adherence or is there an issue of resistance already creeping in. And so again, if we look at our Department of Health guidelines, with a viral load of over 1,000, we would want to repeat viral load within 2 to 3 months. And we want to make sure that during that 2 to 3 months, adherence is as good as possible. And we need to explain that to Sipho, that we're trying to test if his treatment is still working. And during that 2 and 3 months, we're going to have to address these issues, especially around the issues around disclosure. So let's assume a lot of these issues we were able to sort out. There was good conversations. This is very much an ideal life sort of scenario. But now 3 months later, we're actually quite happy that now he is taking his treatment quite well. He's understanding his illness better. He's more or less settled now, living in Johannesburg with his mother. And now you repeat the viral load and it is still high. CD4 count is 420. And the counsellor, when she sees the result, tells him that he's lying about taking his treatment, as it can't be if his viral load is still elevated. So is this true? Is this all still an adherence issue? Or may he have resistance? And if we do think of resistance, which drugs do we think he might have resistance to? And unfortunately, with our first-line regimens are not nearly as tough as our second-line regimens or our PI-based regimens, and Sipho may already have resistance. Even if we are suspecting that adherence still might be the issue, we certainly would have to have a little chat with the counsellor on the side that being critical and judgmental and accusing our patients is not going to increase their ability to take their ARVs. But our first-line regimen is not very tough. So efavirenz, you only need one mutation to lose that ARV, and with 3TC also a single mutation will knock out. And so it's a very good chance that he might have already lost efavirenz and 3TC. Because of the resistance of cross-resistance of nevirapine, if he had any PMTCT exposure in the past, probably unlikely as he's already 10 years old, that could also have affected the ability of his efavirenz to work. But he might also have already inherited a resistant virus from his mom. And then, of course, if he's lost those, he might already have lost a backcover as well. Also a single mutation, not quite as easy to form as the mutations for efavirenz and 3TC. But at this stage, if somebody's been failing while they're taking their treatment, we'll be concerned that he's already lost his whole regimen. So at this point, we have to talk a little bit about cross-resistance, because it's one of the reasons why, if we already see there's resistance to the first-line regimen, or we're suspecting resistance to the first-line regimen, why we are nervous about keeping patients on first-line for too long. And it's possible that the mutation that the virus forms against one particular drug can already cause resistance to other drugs, usually in the same class, which means that even if the patient has never been on that ARV before, they will already be resistant to it, and therefore we can't use it in our second line. So the general rule is there's no cross-resistance between the different classes of ARVs. So if you want to be safe, if you change from one class to another, like we do when we change from the NNRTIs to the PIs, we can be very sure that there's no issues there. But within the NRTI class, we do have some cross-resistance, especially between AZT and D4T, and we'll talk a little bit more about that in a minute. But our NNRTI class is the most problematic from this point of view, with a high level of cross-resistance between our efavirenz and our nevirapine. And we normally assume if you've lost one, there's a very good chance that you might already have lost the other as well. The PI classes, there are some cross-resistance, but it takes a much longer period of time, and it depends. There are different groups within the PI classes that have more cross-resistance toward each other than others. And usually when you start being concerned about cross-resistance, the genotype is going to be the only way that will really clarify that question. This is a few slides to remind us of some of the mutations, and it's repeating some of what we learned in our lecture on HIV resistance in adults. In children, the M184V is a very, very important mutation to know. This is the classic mutation that the HIV virus undergoes, and it becomes resistant to 3TC. The advantage of this mutation is that it cripples the virus. So although the virus is mutated, that virus doesn't replicate nearly as well as our wild virus does. And it also has the advantage that it can delay the emergence of thymidine analog mutations that's going to give resistance to AZT, D14, eventually TDF. So it can actually make it easier for the virus to be killed by some of these other drugs. This is only in the beginning. On the long term, if there's lots of mutations, this particular effect might be overcome. But it's also a concern that M184V alone might also reduce the virological response to abacavir. So there is some pediatricians that would consider using 3TC monotherapy on its own in a patient where adherence is a major problem. You're concerned about starting them on second line. And what you do is you select for a cripple virus, which does slow down the disease progression. This is not a popular option, should only be chosen by pediatricians, and we'll discuss it a little bit more further on. So the other major group of mutations we need to be very aware about is our thymidine analog mutations, which is particularly associated with stavudine and zidovudine. And unfortunately, it confers quite a high level of resistance. And as soon as you've got 3 or more of those, it's going to start also affecting some of your other NRTIs. You'll start seeing cross-resistance. Now, the challenge is the longer the child is left on a failing regimen, the more of these thymidine analog mutations are going to develop. And we're not entirely sure on which TAMS will necessarily form and therefore which drugs will eventually get knocked out. We'll make a quick comment on K65R, which is to do with tenofovir and is relevant for our adolescents. And it results in cross-resistance to a lot of the NRTIs, but not to AZT, and this is actually a great advantage. But it can select for mutations also for DDI and abacavir. Now, the mutation has an antagonistic effect when you have thymidine analog mutations, like you will find with AZT. And this is the classic reason why, if you are failing on tenofovir, we like to use AZT, and if you're failing on D4T AZT, we like to use tenofovir. We don't really like using abacavir and tenofovir in the same second-line regimen as they do select for the same mutations. So when would we consider changing somebody's treatment? There are scenarios where there might be toxicity or intolerance of drugs, and you would consider a single drug switch. In those stages, we actually want the viral load to be suppressed. If it's not suppressed, do consult with an expert to look at what's the safest switches one can make in those circumstances. But by far the most common reason we would switch is for treatment failure. And very important, we will use biological failure as our main reason for changing. In South Africa, we're using a biological threshold of 1,000 and having had a virological viral load of over 1,000 twice. One can also look at immunological criteria, so that has to do with the CD4 count, or clinical criteria. But those are two, usually immunological failure and clinical failure would follow once biological failure has happened. We're trying to prevent patients progressing to immunological or clinical failure. Also with specific drug interactions, we might have to adjust our regimens, but it's uncommon with the regimens we have at the moment. So in which scenarios may you not change to second line even though you are suspecting resistance? And probably the most important scenario is when you have a patient who's actually quite sick. So as a district hospital, we often have patients that we admit that's already in clinical failure. They have an infection. You might be initiating them on TB treatment. They might have a very low CD4 count with an opportunistic infection, a new opportunistic infection. And we will first manage that infection before we're going to switch them to second line. And quite often when you look back, you will notice that they've already been virologically failing for quite some time. And these patients are all at a high risk of IRIS. So if they've got a low CD4 count or a very high viral load, as you put them onto ARVs, you might cause a paradoxical IRIS of the opportunistic infection that they have. Also very important to not switch until you've sorted out any drug interactions that might be affecting your dosing, or making sure they're on the correct dose of the regimen that they should have been on. And that's one of the reasons why we have these viral loads at least 1 or 2 months apart, and have confirmation that it definitely is biological failure due to resistance and not due to other factors. So our choice of second line on children on abacavir, 3TC and efavirenz is very straightforward. We would use AZT, 3TC and lopinavir, ritonavir. Just note, children who was on D4T before, the second line regimen is AZT, abacavir and lopinavir, ritonavir. The reason for that is we are concerned that if the patient was on D4T, there may already be TAMS towards AZT, so the AZT might not work as well as we are going to hope. And the abacavir, which is a new drug, will keep going the M184V mutation, which is what we normally use the 3TC for, and it's just to give that AZT a little bit of extra cover. So let's continue with Sipho. And in Sipho's scenario, we did these 2 viral loads. We discovered that he is taking his treatment, and so he was changed to second line. AZT, 3TC, lopinavir, ritonavir after the baseline test for second line had been taken. And he returns to his family in Mpumalanga, and you don't see him again for a couple of years. Now he returns, and when we look back, we can see once he was on second line, his viral load at 6 months was 24,000, at 12 months about 67,000, and at 8 months 546,000. So what do you think is the cause of Sipho's high viral load? And in patients who are not suppressing on second line, you can be about 98% sure that the problem is adherence. The second line drugs are very different than our first line drugs. So he has failed on abacavir. We're now using AZT, who's got a completely different profile of mutations. The 3TC is keeping the M184V mutation going. And the lopinavir ritonavir is a completely different class. And so we would expect reliably that all of our patients going on to second line is going to be suppressing at 6 months. What we find in reality is that only about 50% of our patients suppress at 6 months. And this is mainly due to the fact that whatever has caused viral load failure in the first place on first line, all of those factors have not necessarily been sorted out by the time we put somebody on second line. So how do we now approach viral load failure in patients on second line? We've already mentioned earlier, it's very difficult to get resistance to a PI, and therefore we will really take our time before we would consider changing this patient to another regimen. And here at this point, I'll mention that the pediatricians sometimes use holding regimens, and this will only be in scenarios where they're fairly sure that the patient does have resistance, either between first and second line or between second and third line. We've already mentioned that you could use 3TC monotherapy on its own while you are waiting either for new drugs to become available, maybe you're waiting for the child to be a little bit older so that they could swallow the new tablets or capsules easier, but you can only do that with an expert, and you can only do that if the CD4 count is high enough. There are also NRTI holding regimens where you have extensive NRTI resistance, and that basically gives a mixture of all of these NRTIs, which means that we're not worried about losing any further NRTIs, as we've already lost most of them anyway. And again, it cripples the virus and just delays the deterioration of disease. Again, this is not for the use of the normal district hospital doctor. But if you have a patient who is failing on second line, there are very clear guidelines on at which point would you consider the next step. And the next step for patients failing on second line is doing a genotype. So there's not an automatic third line regimen like there is a standard second line. It will always be depending on your genotype result. And you'll see there if the viral load is over 1,000 on second line for more than 1 year already, you will be doing all your ABCD interventions. And then you will repeat your viral load in another 6 months after that. So there's no rush when somebody is failing on a lopinavir ritonavir based regimen, unless, as we've said earlier in part 1, they might have been on TB treatment and the ritonavir was not super boosted. And you can see there, if you now repeat the viral load in 6 months and now the viral load again is over 1,000, at this point, if you are sure of good adherence, very important, we can now consider to do a genotype to check for PI resistance. And this is the $1,000,000 question. Is this patient now resistant to lopinavir ritonavir? For if they are, then we would consider a third line treatment. There is no consideration of either genotyping or third line in patients who are still poorly adherent on second line. So your first priority is going to be sorting out adherence, adherence, adherence. When we then do the genotype, the results of that genotype is going to be forwarded to a specific third line committee that is based in Pretoria, and all of the third line considerations happen centrally through that committee. You can't order the drugs on your own through your local pharmacy. There's a very specific third line standard operating procedure, which is part of the Wits RHI packs, and I'll just highlight 1 or 2 things in the paperwork. very important when you send in your genotype that you have to give a complete rare history of any previous regimens, including PMTCT. Very important with the children. You cannot actually interpret your genotype result unless you have this history. And very important to give very good proof that your patient is adherent. And if they are not adherent or you're not sure of adherent, then your patient will not yet qualify for third-line treatment. Now, you won't ever use this algorithm, but this gives you an example of how the third-line committee will actually decide on using or creating a third-line regimen. And this is the one for children over than 3 years or older than 10 kilograms and who's not yet eligible for tenofovir. And the first thing they're going to look at is if there are PI resistance. And if there's PI resistance, then we would use darunavir standard within that regimen. If you can't use lopinavir, ritonavir anymore, you will plus your 3TC because that keeps your M184V going. And you're going to plus either AZT or abacavir, depending on who's got the lowest score, so which one has the least resistance. And then depending on what the score is for that AZT and abacavir, so say you're using AZT and the score is still over 30, or the darunavir is already showing some resistance, cross-resistance, then you will also add in raltegravir. And again, if we see there's also resistance to your tenofovir, AZT, abacavir, and your darunavir, and your etravirine is not showing much cross-resistance yet, you can also add etravirine. So one can easily end up on a regimen with 4, 5, or 6 drugs to be able to ensure you've got a robust third line. There are regimens if genotyping is not available. We're not going to cover these in detail at all because we fortunately have access to genotyping. But there's a standard regimen then of using lopinavir, ritonavir, efavirenz, and 2 NRTIs, preferably ones that's not been used before. And then depending on the virapin contact in the past, you might add in specific drugs as well. And your backbone also will determine depending on what's been used in the past. But these rules we don't standardly use for patients who will use our genotype result. Another complicated case I wanted to highlight is small children or babies with hepatitis B infections. So Margaret was diagnosed with HIV and hepatitis B when her baby was 3 months old. And they tested her baby and discovered that the child had both HIV and hepatitis B. So which regimen would we start baby Margaret on? The issue here is that we have treatment for hepatitis B, and they happen to be some of the same ARVs that we use for HIV. So tenofovir, 3TC, and FTC are all effective against hepatitis B. The challenge is you have to use dual therapy to suppress the hepatitis B viral load. So you have to use a combination of tenofovir and 3TC or tenofovir and imitricitabine if you want to suppress hepatitis B viral load and not develop hepatitis B resistance to tenofovir or 3TC. So this is a problem because if you've got a small child under 2 years old, you're not going to be using tenofovir. And yet if you were to put the child on abacavir, 3TC, and lopinavir, ritonavir as per our usual regimen, that child is going to develop 3TC resistance to the hepatitis B. And that means we won't have that option then when the child is old enough to use tenofovir. So the bottom line is we want to preserve the 3TC for future use. And so the regimen we use in these children with hepatitis B is abacavir, AZT, and lopinavir, ritonavir. And note, they're therefore not on anything for their hepatitis B, but if they're old enough and once they qualify for tenofovir, we can then use tenofovir and 3TC as a treatment for both their HIV and their hepatitis B. So lastly, we have a slide on switching our children from abacavir, 3TC, and efavirenz to tenofovir when they're old enough. Please note we would not do this in children who are on lopinavir-based regimens. And there's very specific criteria on when you can switch your abacavir to tenofovir. Very importantly, the child must be over 15 years old. So as soon as they've turned 15, they must weigh over 40 kilograms. They must have an EGFR of over 80. And note, the only way you can calculate the EGFR in over 16-year-olds is to use your formula, your creatinine clearance Cockcroft Gold formula, or you can use the formula in this slide for your adolescents under 16 years of age. And the viral load must be LDL. So again, very important, they must be old enough, they must be heavy enough, their kidneys must be good enough, and the viral load must be suppressed. And if all of those criteria are met, you can switch your abacavir to tenofovir, which means they can go onto the single-dose tablet. Just to remember, once you've done that, you need to monitor the kidneys as we normally do with our patients with tenofovir, and doing your urine dipsticks at each visit to check for early challenges on the tenofovir. So in summary, a last few key things to remember. Your most important thing to do in failure is to correct the adherence problems. And again, please see our e-learning module on adherence for a worksheet to help you assess your patients for adherence issues. Resistance testing always needs to be considered in the right framework. We do not do resistance testing on first-line failures on abacavir 3-decene efavirenz, but look at your criteria for children failing on lopinavir, ritonavir. If they meet all the criteria, resistance testing might be indicated. Don't ever add a drug to a failing regimen. If somebody is failing, do not do a single drug switch or add any single drugs. If you need to change because of toxicity, discuss those patients. And holding regimens can be used in certain scenarios, but they're not to be taken lightly and not to be used by the normal district clinician. And most importantly, with children, feel free to phone a friend. Experts are happy to be called. The pediatricians in Eastern Cape especially is very open for discussions and questions, especially when you're considering resistance testing or switching children to second line. Always make sure that you have somebody else to support you with these children to prevent both keeping children on incorrect treatment for too long or switching children unnecessarily too early. Thank you.